Bismillah ar-Rahman ar-Rahim. Today we are going to talk about acute correction of adolescent Blount disease. I'm Hisham Ashry, consultant orthopedic and limb reconstruction surgeon of military hospitals. Blount disease is either early or late starting Blount disease. Early is infantile, which usually starts at the age of 3 years, and usually it is bilateral. But late starting or adolescent Blount disease is starts at the age of 10 years and usually less severe because it starts late and there is no much for the sound epiphysis to grow in relation to the diseased one. It's less common than the early starting or early Blount disease, and it's less severe as well, more likely to be unilateral. It affects only one limb, and there is no gender preference. It's more common in Africans or African Americans or dark races. Lange-Scholed classification is a staging rather than classification because it describes the changes which happen progressively to the medial epiphysis, which ends by fusion of the medial side of the epiphysis and oblique orientation of the medial tibial condyle. Acute correction can be done in later stages. We are discussing here the management of Lange-Scholed either stage 5 or 6, where the medial physis has fused. And our case today is a 13 years old female. She had a puberty a year and a half ago, and the mother gives a history of progressive bowing of her left leg, and the right is free, marked limping because, of course, of this leg length discrepancy and the bowing, and there is obvious thrusting of the left knee while she's walking. This is an X-ray, and the scanogram shows pelvic obliquity, shortening of the left tibia, and depression of the medial tibial condyle. We can see here the obliquity of the medial condyle in relation to the lateral one, and it is very clear that there is an angle about 45 degrees. Together with the bowing of the metaphysis, we can see here there is a good bowing of the metaphysis. So we have two deformities, the medial condyle and the bowing of the metaphysis. The medial condyle depressed and the metaphysis is in varus. So planning the operation and illustrative description of the steps of the operation. Number one, we have to do the fibular osteotomy first thing in the operation, because it is important not to forget doing that fibular osteotomy. The correction is going to be marked, and we can't do that correction without breaking the fibula in order to obey the correction. So step number two is doing a vertical incision exposing the medial tibial condyle, and that about 7 centimeters. It has to be planned, and we have to know the places of the half-threaded pins we are going to insert, because these pins are going to move from that very oblique position into a horizontal one. So it must be it must have a free path to go till its final position, otherwise it will cause damage of the skin and will prevent the wound from healing. And then we insert two threaded pins behind each other, parallel to each other, in the medial side of the epiphysis till the center of the tibia. And step number 3 is doing osteotomy, starting from the axilla of the deformity. And we can see here the osteotomy goes to the center of the physis. And sometimes we can cross the physeal scar and go a little bit inside the epiphysis. And the next step is to use a very broad osteotome to raise the medial tibial condyle, together using that broad osteotome or wide osteotome and two chassis screws to elevate the medial side and the medial condyle. And as soon as we reach the level we need, we proceed with the two threaded pins into the lateral half of the epiphysis to support the correction. So we have now an open wedge osteotomy, open wedge medial osteotomy, and we can put a laminar spreader to keep that space, or just leave the two half-threaded pins in place to maintain the correction. Next step is to do metaphyseal osteotomy, and it has to be done as metaphyseal as possible. Don't maybe a couple of centimeters, just 2 centimeters or 1.5 centimeter distal to the first osteotomy, in order to stay in the metaphysis as much as possible for better healing. And of course, it's very important to do some lateral translation of the diaphyseal segment to correct the mechanical axis of the lower limb. So it needs lateral translation. It's very important to not forget that lateral translation. And then we complete our frame in this way. On the left-hand side, the X-ray, we can see the the half-threaded pins or two chassis screws behind each other, together with the two wires crossing each other, holding the proximal fragment. This is the proximal ring, and the distal ring is purchasing the diaphyseal segment with a translation to correct the mechanical axis deviation which was there. In the lateral view, you can see the perfect alignment in lateral view. And the advantage of having a Lizaro frame is we can do fine adjustment to correct the position or the angles in every plane. This is 6 weeks after the operation, when the second osteotomy started to heal. We can see crossing callus, crossing the osteotomy, and remodeling, a little remodeling, and the open wedge osteotomy is still not full of bone yet, but it is progressing in fusion. As I've said before, the advantage of having Lizaro frame is we can do fine adjustment, so we can increase the angle or decrease the angle of the distal fragment. According to the scanogram, you can see here the perfect mechanical axis of the left lower limb, and it's exactly similar to the right one. And we can also correct rotation and correct shortening if we need. After removal of the frame, we have applied above knee cast, and we can see the triangular defect which was there is now full of bone, and the distal osteotomy is again fully united. This is a mechanical axis of both lower limbs, and we can see the equalization of both lower limbs after full correction and union. And this is close up for the left knee, and we can see here the complete union of both osteotomies and perfect alignment. This is after removal of the cast. We can see the reasonable range of movement before even starting any physiotherapy, and we can see perfect alignment of both lower limbs. Thank you very much.